Good evening, everyone. I am Dr. Fatima Azarati, DT, and I will be presenting my second EBM tonight. My objectives are as follows: to review basic concept on EBM on therapy, to critically appraise an article on the effect of selenium supplementation on reproductive outcome, and to apply the result individually in my patient on question. EBM is a systematic approach to the acquisition, appraisal, and application of research evidence to guide questions in healthcare. This allows practitioners to assess new as well as old technology in an efficient and logical manner without being intimidated or overwhelmed. This approach required three sets of skills: acquisition, appraisal, and application of evidence. Tonight, we will go through it one by one. This is my case for this evening. I was presented by LD, a 37-year-old G0P0 non-pregnant who had acne breakouts and irregular period in the past, where she was diagnosed with polycystic ovary syndrome on Metformin 500 mg per tablet once a day. Her office mates mentioned selenium supplementation for good chances in pregnancy. Hence, she phoned in to inquire on the effectivity of supplementation with her maintenance as to her chances on pregnancy. With that being presented, a dilemma came in. In the acquisition of research evidence, we ultimately begin with a clinical dilemma that was either raised by our patient or something we the doctors have thought about too. And to include under acquisition of evidence, apart from the clinical dilemma, this is also where we research and retrieve information. Using my case presented earlier, this is my clinical dilemma. Among reproductive age women diagnosed with PCOS, how effective is metformin plus selenium in increasing pregnancy outcome? We then proceed with search and retrieval of study. So using the PubMed as my website and using the Boolean method as my search method, inquiry about PCOS women and selenium supplements and pregnancy was included. There were 20 articles found, and I deduced it through text availability of randomized controlled trials with time frame of 5 years. With that, I am presented with this article, and I selected this because it encompasses the article or the picture of my clinical dilemma. The study presented is a randomized double-blind placebo-controlled trial that was conducted on 64 women ages 18 to 40 years old with PCOS at the clinic affiliated to Ardabil University of Medical Sciences, Ardabil, Iran. The aim of the study was to determine the effects on the reproductive outcomes, biomarkers, inflammation, and oxidative stress in women with PCOS on selenium supplementation. Now that we have created a focused clinical question, and we already conducted the search and retrieve information, we proceed with the appraisal. At this point, we will be checking on the directness, validity, and the result of the article on study. Appraising directness. So directness, this is how directly does it address the question raised. Does the study provide a direct answer to our clinical question in terms of the type of population, intervention, control, and outcome? For this study, presented to you is the table where the population in the clinical dilemma was similar with the article. Intervention of metformin plus selenium was also the same in the clinical dilemma and article on study. And the outcome was also similar. The pregnancy rate in the clinical question and the reproductive outcome in the article, which was actually determined using pregnancy rate and decreased episodes of alopecia and acne. So, we can decide at this point that the article corresponds to the population, intervention, and outcome in the clinical dilemma and the study to be appraised. Hence, we can say that the study is direct. We proceed with the appraisal in validity. So when we say validity, this refers to how close we think the study results are to the truth. We will be presented with multiple validity questions. So these are the primary validity guide and the secondary validity guide. So this guide or these sets of questions are going to help us to appraise for the validity of the article. So let's proceed with the validity of question number 1. were patients randomly assigned to treatment group. So when we say randomly assigned, this is the best technique to ensure that the treatment group are comparable. So for this study, patients with PCOS were randomly divided into two groups. So to answer that, it is yes. Second validity question is, was allocation concealed? So when we say allocation concealment, this is the random order by which we assign patients to treatment group. So to answer this, we must check if there were sealed opaque envelopes during the study. So in my study, it made mention that patient allocation and block size were obtained using random number tables. At the time of randomization, sequentially numbered sealed envelopes were opened. So to answer this question is yes. Now we proceed with another validity question. Were baseline characteristics similar at the start of trial? So with this, baseline characteristics tend to be very similar when a study is randomized. So it means inequality, if ever arise, may be due to chance alone. So if we look on the left side, it made mention of the inclusion criteria of the study, and on the right side, it made mention that general characteristics of study participants were not significantly different between Selenium and placebo group. So with that, we can now answer that question number 3 as to yes. Questions number 4, 5, and 6 talks about blinding. So blinding is the attempt to make treatments being compared indistinguishable. So validity question number 4 made mention, were patients blinded to treatment assignment? The answer to this, the present study is a randomized double-blind placebo-controlled trial. Another question of the validity, question number 5, were caregivers blinded to treatment assignment? Supplements and placebo were of the same form of package, and the patient and researcher were not conscious of the content of the pack until the end of trial. So caregivers blinded, this is where we check when study presents such as use of identical preparation. And last, were outcome assessors blinded to treatment assignment? So this is where we check on the investigators or researchers that are blinded to treatment assignment. So example to this, the clinical data was withheld or assessments were independent. However, in my study, there was no mention of this. So to answer, it was only validity question number 4 that answered yes, and validity question number 5 that was answered yes. Now we proceed with validity question number 7. Were all patients analyzed in which they were originally randomized? So patient in trial may not comply or adhere to treatment. Reasons can be they forget to take the drugs, intolerable side effects, or they refuse to go on. When that happens, a dilemma will arise. Should they be analyzed in their original treatment group or should they be excluded? This is where we check for intention to treat to answer the question. So ITT is a statistical analysis that maintains prognostic balance generated from the original random allocation. So if we look on this, it made mention that the analysis was done according to the ITT protocol, that all 64 patients with PCOS were included in the N analysis. So if we look at the summary of patient flow diagram, that the randomized patient were allocated in placebo and intervention, and this number of patients were still analyzed at the end of the study. So to answer this validity question number 7, it is yes. We proceed to the validity question number 8. So, was follow-up rate adequate? So, the greater the number of patients lost to follow-up, the more the study validity is threatened. Meaning, the crucial issue here is ascertaining whether or when to worry about the number of dropouts. So, accordingly, a dropout rate that is more than or equal to 20% is substantial. But for my study, if you would see, the dropout rate was only 12.9% on this study. So the loss to follow-up was not substantial in value. So to answer validity question number 8, the answer is yes. Now I present to you the summary of the validity question presented earlier. So for an article to be valid, the article must fulfill at least 1 primary and 2 secondary validity guides. So attempting to be strict and insist that all 8 criteria be satisfied, we must be pragmatic and remember that sometimes we need to make medical decision based on less than perfect information. So with that, this article presented with 3 primary validity questions that was answered with yes, and 4 secondary validity question that was answered by yes. Hence, we can conclude that this article is valid. At this point, we all know that the article is already direct and that the article is valid. Now we will be appraising for the result in order to interpret and individualize it to our patient. When appraising for the result, there are two questions that needs to be answered. First, how large was the effect of treatment? And second, how precise was the estimate of the treatment effect? So to answer number one, the magnitude of the treatment effect may be expressed by comparing the outcome in the treatment and in the control groups. There are two kinds of variables, but for this study, the presented variable is dichotomous, which have only one of two possible results. So for my case, pregnancy or non-pregnancy. So to measure the effectiveness for dichotomous outcome, we need to study the relative risk, the absolute risk reduction, and the relative risk reduction. However, in the syntax of my clinical dilemma, the outcome was not a bad outcome. It was instead a good outcome. So pregnancy rate is not a risk. For a study with good outcome, the only value needed to compute is the number needed to treat, while with NNT, we will also need to get the event rates and the ARR, or the absolute risk reduction, which I will present later. Flash before you are the result of this study. So after 8 weeks of intervention, the pregnancy rate in Selenium group was higher than in placebo group. So by eyeballing, we can see that there were 6 patients under Metformin plus Selenium who became pregnant, and only 1 patient under Metformin plus placebo who became pregnant. So with that, we can now compute for the experimental event rate by using the number of the non-pregnant over the population in the experimental, while the control event rate is the number of non-pregnant over the number of total patient being analyzed. So our event rate for the experimental is 0.8125, while the control event rate is 0.96875. Now that we compute for the event rate, we will be determining the ARR use. So by principle, the ARR is the proportion of patients who got the outcome as a result of difference between the control and the treatment group. So computed before you is the event rate of the control minus the event rate of the treatment, which is 0.1563. This is expressed as 15.63% ARR. So again, for EBM on therapy such as this one, where we computed for the good outcome of an intervention, we are more likely looking on the absolute risk increase in the article of therapy at question. Now that we already know what is the ARR, we can compute for the NNT, so number needed to treat, which is 1 over 0.1563, which gives us to a number of 6.40 that we can round off to a result of 6. Meaning, for every 6 patients treated with Metformin plus Selenium, 1 patient will have a pregnancy outcome. At this point, we've already answered the number 1. Let's proceed to the question number 2. How precise was the estimate of the treatment effect? When we say precision of the study, this aims to give an idea how confident a study estimate to the treatment effect. So the precision can only be known by the confidence interval. Given the study, there was no report of confidence interval. However, p-value was mentioned in this study. So when you say p-value, this signifies that there is difference between two groups, and the p-value computed for pregnancy rate was at 0.004 in the article, meaning the result was less likely by chance, but it is more likely by the intervention. At this point, we have covered the acquisition of the evidence and the appraisal of the evidence. We move forward to the application it to our patient. So the questions such as under the assessment of the applicability, we have to determine biologic issues affecting applicability. So as to the age of my patient, which is she's still 37 with no known comorbidities presented earlier in the case, her race is Asian, in comparison to the study where it was tested among Iranian women. Hence, I believe that there is no biologic issues affecting the applicability. Another concern is the socioeconomic issues affecting applicability. Most trials are carried out under ideal conditions, which are difficult to apply in an everyday life. So patient compliant problems and provider compliant problems arises. So with the availability of medicine and the willingness of the patient to take in, I believe that compliance will not be an issue for my patients, since this will be taken as a once-a-day regimen in an 8-week period. So my answer is none. Now that we already assessed the applicability, we move to the individualization of the result. and the benefit, the risk, and cost to our patient. So there are multiple questions here that we need to answer. One, were study participants similar to my own patient? I believe this is a yes because the patient presented with infertility concern. In the study, it included 18 to 40 years old Iranian women who were attending to the clinic fertility who were diagnosed with PCOS. None use any treatment aside from their metformin. Hence, I can sufficiently be comfortable to use this result with my population in clinical dilemma. Another question is, were all clinically important outcomes considered? Researchers may use several different outcomes to test the effect of treatment. So in this study, there were no safety issues presented in my article. Other outcomes such as biomarker and oxidative stress had beneficial effects actually. So I believe the answer to this is actually yes. Another question is, are likely treatment benefits worth the potential harm and cost? So I've researched that selenium 200 microgram in Kirkland and Healthy Options available in Beauty Manila is at 2,000 pesos for a 120 tablet, meaning one tablet is 16 pesos. And if it is applied to her, she will need around 56 tablet or about 934 pesos. Hence, the answer to this question is yes. Article for me is quite strong in terms of its method and I'm confident in its findings. So the participants were truly randomized, remained blinded as to their group assignment and follow-up was adequate. For the resolution on my case, I can now advise my patient, intake of metformin plus selenium is effective in increasing pregnancy outcome using this study. It was calculated that in every 6 patients taking this combination therapy, it had one outcome of pregnancy. This will also cost her at 56 pesos per tablet and completing an 8-week therapy will cost her around 934 pesos with a once-a-day regimen, and for someone who is employed, this is not considered very costly. So again, for the purpose of re-emphasizing the article we have studied, we can also compute for other outcomes that was presented in this article. So if you can remember, my case was also presented with acne breakouts in her history. Hence, a sub-question was then formulated. So among reproductive age women diagnosed with PCOS, how effective is metformin plus selenium in decreasing acne? So we already appraised for the directness and validity. We can now proceed with the result. Again, as emphasized earlier, the magnitude of a treatment effect may be expressed by comparing outcomes in the treatment and in the control. So there are two kinds of variables. So for my case, an increase or decrease of acne occurrence. So to measure the effectiveness for dichotomous outcome, we need to study for the RR, ARR, and the RRR. However, in the syntax of my clinical dilemma, the outcome was not a bad outcome or an adverse. Instead, it was a good outcome. For study with good outcome, the only value needed is to compute for the number needed to treat. And in order for us to do that, we need to get the event rates and the ARR, which I will present later. Flash before you are the result of the acne decrease between the experimental and the control. If you can see in the computation, the experimental event rate was 0.53125 and the control event rate is 0.875. With that, we can compute for the ARR, the event rate in the control group minus the event rate in the treatment, giving us 0.34375, expressed as ARR of 34.38%. So again, for EBMM therapy such as this, where we compute for the good outcome of an intervention, we are more likely looking on the absolute risk increase in the article rather than the absolute risk reduction. With that, we can now compute for the number needed to treat, which is 1 over ARR, giving us the answer of 2. So to interpret, for every 2 patients treated with metformin plus selenium, 1 patient will have a decrease in acne. As we go to the application of this result, we now search for or answer the assess of applicability. Again, we've mentioned that there is no biologic issues affecting applicability and there is no socioeconomic issues affecting the applicability. We now move forward to the individualization of the result. So we have already answered that the study participant was similar to my patient, that all clinically important outcomes were considered, and the likely treatment benefit is worth the potential cost of the patient for the patient. my resolution to this subset question, we can now advise to my patient, intake of metformin plus selenium is effective in decreasing acne. Using this study, it was calculated that in every 2 patients taking this combination therapy, it had one outcome of decreasing acne. This will cost her at 56 pesos per tablet, and in total, completing at 8-week therapy will cost her around 934 pesos. Hence, this concludes my acquisition, my appraisal, and my application on the EBM on therapy. So my insight on this EBM is we have to be acquainted with the usual syntax of the therapy, where we look upon our population, the intervention used to prevent an adverse outcome. I learned that there's still way for articles to be appraised even they are written in a good outcome or written in an increase of a good outcome. Thank you so much. That concludes my EBM for therapy tonight. God bless everyone.